thank you very much for joining us today on our second in this three-part webinar series on neighbourhood teams. First, just a little bit of housekeeping for everybody. So we are recording today and your videos and microphones have been switched off just while we go through the presentation. But if you do have any questions, please pop them in the chat. We'd like to encourage some questions. And then we've also got a Q&A session at the end where you'll be able to come and ask some of our speakers some questions. If you haven't already registered for this session directly through a link, so if you've joined by a link that was shared by somebody else, can you please just make sure that we've got your email address and job title in the chat so that we can make sure you've got the follow-up information from the session today. And today's presenters, myself, Claire Temple from Redmore Health, and Rachel Edwards and Alice Benton from At Scale. We're also joined today by Dr Lauren Parry, who's GP and Medical Director for Hertfordshire General Practice, Taurus Healthcare and Primary Care Analytics, who'll be sharing some population health case studies with you. And then we're also going to be joined by Kamal Bahia, Integrated Neighbourhoods and Regional PCN Development Lead for the South East region, who'll join us at the end for the Q&A session. So thank you very much to both of them for joining today. So this session today is again brought to you by the D&T Network. So the Digital and Transformation Network came to life in September last year with an aim to connect everyone across healthcare interested or involved in digital and transformation. We've currently got over 1,200 members from primary care, and we'll shortly be looking to add a community and voluntary category to broaden the discussions for neighbourhoods in there. So if you're not already a member of the D&T network, you can scan that QR code that's on the screen, but we will be sending out invitations after the session as well. So just a reminder that this is the second of the three-part webinar series. If you haven't already registered for the next session, we will pop that link in the chat for you so you can register for that. But just a short recap on what we looked at last time. It was the foundations for integrated neighbourhoods. So talking about the 6 components and how they connect to sort of modern general practice access. We looked at the expectations for GPs, PCNs and ICBs, and a little bit on governance for MDTs. But most of all, we looked at real life case studies from a few people that were really, really informative. So we won't linger on that. There is a readiness assessment available for you in our D&T hub. So if you haven't already had access to this, we'll be sending that information out to you afterwards. But understanding where your neighbourhood is and how ready it is, this can help you try and find out what areas you might need to think about in a little bit more detail. So you'll go in, you'll do a short global assessment which covers everything, but then you get the option to do the neighbourhood readiness assessment. And now I will pass over. Oh no, I've got to do the agenda. Today, this is the agenda for today. So we're going to be looking at the underpinning guidance for neighbourhoods. It is fast moving. We know that a lot of places are moving on with neighbourhoods quite quickly now. We're going to look into population health management and some case studies of where that's been used in practices and PCNs. Then we're going to look at the leadership, workforce planning and skill mix, and that'll include sort of looking into partnerships and MDTs, and then some information on funding and financial planning. And then last but not least, we aim to have some time at the end for that Q&A session with our experts on today. So thank you. I'll pass over to Rachel.
Hi, I think I've got the take control button. Thanks very much, Claire, and it's great to see some of you introducing yourselves on the chat as well. We've got a great mix of attendees today from our health, primary care, ICBs and our community, voluntary and faith sector. So hopefully it will resonate with all of our sectors, as this is really focused neighbourhood. We touched at our last webinar around sort of what underpins the changes that we're looking at, and this is the 10-year plan that came out in July. It feels like it came out ages ago, but as we've had subsequent frameworks that have been issued since then, there's lots there. We're not going to go through it, but there is a lot online. Your ICBs and your voluntary community sector leads will hopefully be able to help you disseminate some of this. But key to this is that there is neighbourhood health, and we have 3 shifts: hospital to community, analog to digital, sickness to prevention. And I think it's the recognition that frameworks need to now start to translate into contracts and operating models. So have I gone on to the next slide? No. Okay, so really this challenges us to look at preventing ill health and what that early intervention means. And it's mental health and well-being, children, young people really focused, tackling health inequalities, improving access to all. We are very much aware in the system that health and well-being is a component and a link to education and housing. Poor housing can lead to poor health, education to employment. We are looking at this whole wider determinants, and this is why it's looking at an individual's needs rather than in siloed sections. And embracing digital innovation, it's not just about robotics in an acute trust. It's about looking at AI, looking at the digital front door, and obviously looking at the long-term sustainability of services and contracts and funding. And we'll talk about that later in the session. And we touched on the last webinar, our 6 components of neighbourhood health, and it'd be really interesting to hear on the chat, for those of you who have started looking at your neighbourhood health, whether these 6 components resonate with what you're looking at, or whether in fact, we need to be looking at other things and other components to include there. Then moving on to the medium-term plan, which dropped about a week and a half ago. And really that underpins the 10-year health plan vision. And it really emphasises primary care being central to what it's going to look like. In primary care, we have registered patients, and although not everyone's registered, the vast majority of the population is registered, and as such, the component part of having an individual registered that services can wrap round is really important. Now, just looking at the bottom there, you'll see that I made a note of the strategic commissioning framework, which was, I think, dropped on Thursday or Friday of last week. And we know that the model neighbourhood framework, which will hopefully give us that next layer of what neighbourhood frameworks, clues in the title, is due in November. And we also know that ICBs will be submitting their plans by the close of play on New Year's Eve, I think 31st, if not before. And here we've got a table that we'll share. I won't go through it. We've got a table here that we'll share of what we thought were the important frameworks and documents that were coming out, how and when, and whether they've already come out, and where you may find them. So hopefully that will be useful to you. And what we have is the strategic objectives in primary care, and that's having access to local services, neighbourhood, wraparound services, early intervention, managing long-term conditions. And we've got lots of those priorities sitting in the frameworks and the vision at the moment. And it'd be really interesting to hear how you are looking at your long-term conditions, and particularly in relation to data management and what else you're looking at, how you're picking population health management up to highlight in your geographical footprints, and therefore what your multidisciplinary teams will start to look like, and integrating across social care, community, pharmacy, local authorities, and adopting the digital first models and unified data systems. And we touched last time on what data sharing agreements would need to look like, and how we can, pulling in our voluntary and community sector is so critical. They are our grassroots organisations. They really know the community they represent, and the data that they hold is going to be invaluable. And obviously we want to see improvement to patient experience. So it's already started. We know the contract variation in October, the new contract came out. How we're responding differently in primary care to that. We've got our pilot PCNs. We've also got pilots and cohorts already established. We're not waiting in neighbourhoods. We're not waiting for the outcomes of those 40 plus pilots. They're already starting, and the emphasis on compliance and performance. We know that ICBs will be required to monitor those contracts and more robustly, and what that's going to lead to. We will need to see how those arrangements roll out. We do know CQC inspections are very much focused on partnership working, the quality robustness in the governance, and where we are working with practices and PCNs on their CQC readiness assessment that we have, and we'll provide the link to that later. Many of those really do underpin, as providers, what you'll need to look like and how robust you need to be to hold those provider contracts. We all know challenges and implications, and I think we have to look at those while we start mapping and planning our own neighbourhoods and what they look like. So today we're focusing on 3 core areas where we have early opportunities, and that's our digital transformation, our workforce, and our contracts and our early adoption of those contracts and our case studies. So hopefully waffle is off, and I will now hand over to Lauren, I think.
It's me.
Was it Claire? Sorry,
That's
Claire.
fine.
Claire.
Lovely. So we're going to look at population health management. So why is population health management important in neighbourhoods? Why do we need to look at that? Because population health management is about understanding the needs of the whole population, not just those that come through the door in a particular practice. So it supports the shift from reactive to proactive care, helping neighbourhood teams target the resources where they'll make the biggest impacts. Population health management underpins those integrated neighbourhood teams. It gives everyone, so the GPs, the community teams, social care, voluntary sectors, a shared view of the local population and its needs. And it's not just a data project, it's a planning and prioritisation tool for all of your local partnerships. So this is the first step. So you need to figure out how you're going to plan your population health management, but then you also need to think about who does this and how often will you review it in your neighbourhood team, and how can you plug in the data from the other voluntary and community services. What information do you need from them for your selected cohort? So how are you going to do that? So understanding the population health management cycle. So obviously we're starting with the data. So combining data from general practice, secondary care and public health to start with. And we'll be looking at data and information sharing in more detail in the next session. But also our Edge tool that's available through the D&T Hub can also help you see from a GP practice, PCN and ICB level for information on things such as the NHS app, online consultations, some QOF information and digital inclusion and public health information that may help you to get some of this information that you need. And then we move on to insight. So use that data, use it to identify the trends, the risks and the inequalities. And then action, design some targeted interventions with the right partners. So once you've identified your cohort, you then need to decide which partners, which community or voluntary services are you going to pull in to support you. And then at the end, it's evaluation, making sure that you measure your outcomes, share your learning and refine. So start with what you've already got. GP clinical systems, dashboards from the ICB or external providers such as primary care analytics that we've got on today, or fingertips data. It's there for you to use. And remember, that the medium-term planning framework now asks for 3 to 5 year plans. So use this data to support that. Now, risk stratification and segmentation is really important as well. So risk stratification, it sorts your population by the level of need or the likelihood of poor outcomes. It could be frailty risk, hospital admission risk, or unplanned care. But segmentation is the groups of people by shared characteristics or needs that we need to focus on as well. So that could be long-term conditions, it could be frequent attenders or high service users, it could be those children and young people with complex needs, or people with multimorbidities or polypharmacy. And by doing this part, you can use it as evidence for your capacity and access improvement plan as well in practice. And then moving on, so identifying and working with cohorts, your approach for neighbourhood working should start with a focus on specific cohorts of the population. So once you've done all of that information, you find your specific cohort. So as with Anita's example from our last session, she focused on the patients who are at risk of becoming high impact users in the future, or some examples that will be shared later on today for child mental health, things like that. But define your goal. So what do you want to do by getting this cohort, by choosing that cohort? Do you want to reduce unplanned admissions? Do you want to improve hypertension control? Decide what your goal is. But as it says here, remember that you're not expected to tackle everything all at once. So start with a pilot, test it, refine it, and roll out further once you're happy with the process. But think about what would have the most potential impact. Every area is different, and you probably already have an idea of what that would be for you. So, in summary, start local. Begin with one neighbourhood, one data set, one priority, and then build up that capability. So upskill the staff in interpreting data. Not everyone needs to be a data analyst, but everyone should understand what that data means. And then use shared dashboards. So the ICB population health tools, GP intelligent platforms, QOF tools. Use all of them tools to help support your information. And then tell the story. Don't forget, use data visually to show trends and impact, because that helps to build engagement and further funding for your funding bids. So I'm now going to pass over to Dr. Lauren Parry, who's going to share her experiences with you. Thank you.
Thank you. Hi, everyone. My name's Lauren Parry. I'm a GP and a medical director for Primary Care Analytics, which is an arm of the GP Federation in Herefordshire. I'm also full of cold today and struggling to hear out of one ear, so apologies in advance. So I really wanted to talk to you about general practice data in the neighbourhood and then the wider use of data across your networks. There is so much rich data already in general practice about our population, and that really is a gift for PCN working, for neighbourhood working. If we ask the right questions, if we see it in a way that makes sense, then we can offer our population evidence-based interventions. So we follow NICE guidance, don't we, in our prescribing? But when we decide who we want to recall or whether we should get an extra nurse in practice or an HCA, it might be more of a gut instinct or a sort of finger in the air. Equally, general practice is really good at quickly testing an intervention. We've probably rolled out group consultations or longer appointments for patients with complexity. But are we using our data to then evidence that that is something that is of value and something that we should be continuing to do? And as we move to working more as a system and understanding the financial and demand and capacity value that has, that's even more important. So I think Claire has mentioned some of these things that are so important when we look at the range of data that we already have. We need to understand what the problem is we're trying to fix. We want to know what we want to know, but what we already know, and test that. So you might already have a feel for the types of patients that are using your system in it a lot, but can we gather the evidence for that? Can we test those hypotheses? What are your potential solutions and what are you working with? There's no point testing something where you don't have a workforce to deliver that or a funding stream to do that. Start with something where you already know that we can work in this particular way. And then think about what good looks like and how you'd measure that, because that's so important to know. Is this doing what we anticipated that it would? So Primary Care Analytics has built a tool, uses 50 million data points of general practice and public health data. And it has a range of different things in it. For example, demographics like age and ethnicity. It's got coding like HbA1c and blood pressure. It's got lifestyle factors, smoking and alcohol. We've got the number of contacts that that a patient might have, either in general practice or ED or hospital admissions. All of that data then is so helpful for us at our fingertips to understand what we can do as a neighbourhood to work. So with a few clicks, we can look at a number of different areas. So this is looking at long-term conditions. We know in the GP contract, there's quite a focus on cardiovascular risk. So you might want to look at your cohort, looking at those patients who've got a cardiovascular disease. And then you want to see, as your population in your neighbourhood, how many patients have you got with those conditions? And if you look at the multicoloured box there, yellow in this particular population shows that the largest long-term condition is hypertension. But if I was to filter that cohort in a different way and to see that patients who were under 20 or patients who were housebound, then the most common long-term condition or the most common reason for presenting to general practice is likely to shift. Understanding that is really important, because if you want to look at your high system users or your high attenders of ED, actually understanding if those patients are housebound patients with heart failure or under 25s with drug use will help you to understand what the solution is for those. Understanding that data is so important. And here you can see it filtered by Rockwood score and by long-term conditions. So if you were looking at frailty, you've got that information there too. So if I give you an example, so Herefordshire, where I work, is a Wave 1 neighbourhood site. Herefordshire is quite a mature system in the way that it works. It's also a really simple system. We just have one acute trust, one community trust, one GP federation that all the practices are part of, one mental health provider. It's very straightforward. We're one of the 43 sites chosen as part of the neighbourhood Wave 1 to accelerate the work that we're doing around neighbourhoods. So we came together as part of a data day. Everybody from who does data for each part of the system and clinical leads to make some decisions about what is the problem as a neighbourhood we're trying to fix. So, you know, we're no different to many other systems. We wanted to look at why we have so many unplanned admissions. We wanted to look at length of stay, high risk of reattendance. And also what was really important when we looked at the data was understanding that actually these people were high users of general practice as well. And sometimes when you're looking to work as a system, when you're looking to work in a neighbourhood, you need to understand that there's something in it for each of your partners around the table. You know, we have a lot of fixation around ED attendances, and sometimes that can turn off general practice. And, you know, we're also drowning in general practice, that kind of mantra. But actually we could see that for these particular cohorts that we were looking at, they were high users of general practice. So actually, if we're seeing this cohort 50 times in a year, we've got an opportunity to work differently. We could do longer appointments. We could do a more intensive intervention and track then. Are we seeing them less? Do we make them 25 but double the amount? We won't change what our system capacity is in year one, but hopefully that will have an impact going forward, and we can measure that. So we knew some things that we already wanted to test. So we knew that, for example, one of the neighbourhoods in our place really wanted to look at frailty. We know that patients with frailty often hospital admission isn't the best thing for them. The same heart failure. We had a lot of admissions for patients with heart failure, and actually we felt that those things, that heart failure is better managed in the community. It's rare that a person would need to be in hospital for that if we could pick that up early. So we developed a bit of a mantra, which was to do a lot for a little and a little for a lot. And so for the people, where a small cohort of people where we're going to do a lot for, we're looking at more intensive care planning and long-term condition support. So that was the cohort we were looking to find. And we were then, alongside that, we're strengthening our admission avoidance for, our admission alternatives for those patients. So we started to look at what good looks like for us, and for us it was about better quality planned and holistic interventions. Our markers were fewer unplanned attendances. We're also looking at improved workforce morale and an improved patient experience. So that's outside of the existing data. So we're tracking existing data, but we're also then supplementing it with some qualitative research too. So we're tagging the cohorts in each of the IT systems, and then we're measuring in each of the individual systems in our patch various elements. So this is just showing you one of the neighbourhoods in our place. So they wanted to look at, so this is the overall population for their neighbourhood. They drilled down to 4 or more long-term conditions. They really want to focus on medical complexity. And then they looked at those people who've had 1 ED attendance in the last year. So they were trying to get people who were not yet high intensity users, but had the potential to be, were at risk of that because of their medical complexity. And so that's the cohort that this particular neighbourhood is now going to track. And here you can see there's a number of details around that. So here we're looking at seeing that these patients are over 75. They're mostly in IMD 1 and 2. It gives us a flavour of what where these patients are, and at this level it's pseudonymized, but actually then for each of the practices within this network, they can now identify those within EMIS searches. Also, we know that there is complexity of contracting in general practice. So this particular network has got 3 different contracts, which all had the potential to overlap. So it's looked that their contracts are looking at frailty coding. They're looking at patients in particular LSOA groups who've been identified as by public health as being at higher risk of cardiovascular and respiratory admissions. And the 4+ long-term condition cohort that we've just seen. So by looking at the data, we've also been able to pull that and say, okay, there is an overlapping cohort, and that might be the first place for you to start, because that will be contractually sensible in terms of meeting your requirements, and there's a helpful place to start, and then you can start to move out to the other areas. So all of this is data-driven. So I'll briefly give you a couple of other interventions. So there was a piece of work that we've done looking to understand how you can use data to look back. So they looked at their cohort of they looked at their population cohort and identified that there were high system users who actually had a lot of conditions that weren't, so high users of general practice, but without medical problems. So presenting with finance issues, housing issues, for example. So they designed an intervention to refer patients to the Citizens Advice Bureau. And then they looked at data before and after that intervention to understand what was the impact on utilization of appointments. And here you can see the types of people that had the intervention, looking at their demographics. And then you can see, by using the data to look at their appointments, you can filter to see, did it have an impact on GP appointments? Did it have an impact on nurse appointments? Did it have an impact on A&E attendances? So it's really important to use once you've designed your intervention, to then look at your data to demonstrate the value of it. And with the way using data that already exists in EMIS or System 1, even though your intervention might start on day 1, you can still go back to your data 12 months ago, for example, and see the difference, and to make sure that you're measuring impact. You don't just have to start from the day of your intervention. And my final example is a solution that was designed around patients for chronic pain. So here they were looking at high intensity users of practices with chronic pain. These patients were frequent attenders and had and were still having ongoing symptoms of pain, were on a lot of pain medications, had been referred several times to various interventions, but we weren't reaching them. So the practices were keen to do something different. So they used their data to identify the population. I then designed a solution that was a holistic intervention using pain specialists and wellbeing coaches. They had an initial assessment, and then they had weekly online coaching sessions. And by using the data, what they were able to see is the things that they wanted, that they looked at to measure: pain medication prescriptions, GP appointments, and referrals. There was an impact in all of those. And there's a monetary value to those things. So being able to tell the system about the reduction in referrals into ongoing systems, being able to demonstrate the impact of reducing prescriptions, is really powerful for them being able to fund ongoing programs in your neighbourhood, because there's a system value to that. Most importantly, those patients also had a reduction in their pain score. So actually, if this was great for the system, but most importantly, it was great for the patients. But by looking at data in a really holistic way, even there were markers that we noticed that were not things that we were specifically measuring as part of the program. And I've just drawn out one of these here. So 22% of the patients were initially hypertensive, and 18% of those were borderline hypertensive. For an intervention around pain, actually, there was a 60% reduction in one cohort of blood pressure to the normal range, and those with borderline, 75% reduced to the normal range. That's a huge impact to a patient. You've removed a long-term condition, and you've demonstrated that by working in a different way in a neighbourhood, by using your data. So I would say, if you're a PCN or a neighbourhood and you're unsure really where to start, or how to define your problem, then start and end with your data, and do data all the way through the middle. We'd be really happy to have a conversation with anybody who's interested in that. And I'll hand you back to Claire. Thank you.
Thank you. Alice?
Thank you. That's a really interesting summary, Lauren, of the population health and the power of the data, and how it can help to kind of shape the discussions and the priorities that are being set in sort of PCN and emerging neighbourhood conversations. And I think it's kind of leads into a little bit around, well, it's all very well having these ideas, having the plans to do something different, and the kind of the intention to build a neighbourhood. But how does this move forward if there isn't kind of clear and emerging leadership? If there isn't the kind of the more formalisation and the pulling together of some of the teams and skills that sit underneath that. So when we were thinking about this session, we were thinking about, it's all very well to have the guidance and the kind of the vision nationally. We know there's a huge amount of data out there that we can harness. We know that there's great opportunities. We know the frustrations that we deal with every day. We know there's great opportunities to do things differently. But how does that get organised locally? And how is that playing out in a way that enables kind of the leaders to come forward, and then the workforce and the resources to be better skilled and planned underneath that? And we know that's going to be playing out really differently in different areas. But we also know from our own experience that a lot of this is coming from the discussions of how do PCNs, with their responsibilities and their resources and their workforce, how do they grow now and expand and increase in their remit and fit within a system and place governance system that means that actually these neighbourhood aspirations are going to start to come to life. And it's going to be really interesting for us to learn from some of the national pilots that are happening, but also we know, and we're hearing through these webinars, that there are great examples happening already. And there are great examples happening already, despite the fact that actually a lot of the contracting and a lot of the future models for delivery haven't been landed yet. So when we've been thinking about, and a lot of the work that we do is with PCNs and their teams and developing that leadership. So when we're working with the areas that we work with, we've been sort of thinking about, well, how do we go from this PCN that looks after this population and think about now that wider neighbourhood mix. And a starting point for this is often around mapping the neighbourhood partners and really thinking about, when you're thinking about the areas of improvement that you want to make, who should we be working with, who needs to be around the table, and where have we got any skills and gaps and things that we need in those people around the table, and how do we think about who is taking that leadership role? How do we manage the responsibilities and build the resilience in those teams? So I think you'll all probably recognise that that the neighbourhood working is building and growing, but it'll be really key to kind of be aware of who in your local community is kind of stepping up and taking the lead, or if they aren't, where are the conversations happening around how this should be coming together? And it might be the case that actually there are gaps, there are new roles that need to be recruited, or staff that need to be upskilled. But that's going to come with the kind of the flow of the work, the prioritization that are recognised within each neighbourhood. And the point that was made at the end there around how the resources can be freed up from other parts of the system to shift the capacity and the infrastructure into the out of hospital space, into the neighbourhood space as it's being developed. We're really conscious that a lot of the information that we discuss is very health oriented. The 10-year plan is a plan for health. The data that we draw from predominantly comes from the clinical system, so the GP systems that we've discussed, or the kind of the information that we've got. But we know that the richness comes when this data set is brought together with other information from other parts of the kind of the public and voluntary sectors around populations. And we know that the skills and experience often sit in those services that sit outside of the health services too. So a massive challenge and a massive opportunity of this is going to come from that ability to bring those teams, that experience together in a coherent way around a population. When we're thinking about a neighbourhood workforce, and I see in a chat around, who links all these together, I think, this builds on what I was saying before about having a kind of a mapping and resource identification at a neighbourhood level. But also, we've been working with areas that have been really keen to define a core neighbourhood team. So who is at the heart of that neighbourhood? And in some respects, some of those staff and some of those people at the table aren't necessarily there because their current job description says they should be, but it's often because it's clear that their role, the impact that they can have, and the ability to fulfill the vision of neighbourhoods means that people need to be thinking about their roles differently, and how they can contribute to that. So some of that comes with seeking permission from employers, but some of it also comes with really making the case for your organisation or your staff members to be involved in those conversations. And when we've heard about the starting point being around identifying those cohorts where, with the wraparound of the expertise and experience and resources of the existing services, it means you can have the most impact, then actually starting with developing those more focused MDTs around those core cohorts is an absolute must. These are the ones that you start with, and this is where the ideas and the kind of the efficiencies in how those pathways for those patients and how they use public and health services can be managed differently. And considering that also in the context of the digital tools that come with that, and how data sharing, both as the challenge that it is, but also the opportunity that it provides, can start to have that impact. Looking at, thinking about that workforce and how they're there and how the resources are kind of used more efficiently might mean that there's some discussions around how people's employment might need to change, or how people might be shifted into certain roles. And we're seeing discussions currently in some areas around secondments or job shares or some shared employment arrangements. And I'll come on to those in a few minutes. it's really important around continuing to look at risk, continuing to look at opportunity, and continuing to ensure that we're not over duplicating or cutting across existing ways that are working well. So this was really just our section here about thinking about workforces. It's not all going to be in our control to do, but it will be important for neighbourhoods to be thinking about the workforce and the resources that are there, how those people can be at the table, so that do things around their contracts or terms of employment need to be different, and how do you manage things when people's terms and conditions are so different and you might want them to be working consistently. We need to think about where our leadership is drawn from. We work with amazing PCN CDs that are stepping up into these roles. And so they've had a clinical director role for a primary care network, but they now are expanding that to look at how they can have an impact across a whole neighbourhood. But we also know that leadership and expertise sits in other sectors and can really complement or support those roles that are going to be needed to lead neighbourhood working. There's all sorts of other things to think about. One thing we've worked with a provider, with a PCN in Redbridge, was looking at the leadership model and knowing that there was a CD who took the lead, but that under the role that CD had, there were other clinical leadership roles that were needed. And so we worked with them to develop a distributed leadership model, which meant that certain other clinical leads could take on the management of new teams, so particularly those that came through the additional roles reimbursement scheme in PCNs, or those that could take on a particular cohort of patients that needed a different solution. So sometimes I think it feels like it all falls to one leader, but often there's leadership that is there, that needs developing, that needs identifying, and that can really support and build the resource that is so precious, because we know people's time is so trying. So we've had a look at some leadership readiness questions, and we've put a little link at the bottom there around though for neighbours to have a think about where their leadership gaps or their development might be needed. Just moving on, just took some case studies now to quickly run through. When we've said things have already started and you're already doing some of this work, we think that the mental health practitioner role in particular in primary care networks is a really good example of how groups of practices to start with, working with their community providers, their mental health providers, have sought to share resource that's often quite precious and hard to come by, but have sought to share that resource to make sure that patients can be cared for in the right place in the pathway. So really keeping patients managed in the community and supporting them, but also supporting general practice to better work with patients with mental health challenges or problems that benefit from having that kind of specialist and dedicated time. So some of you will have really positive examples of how this has happened, and some of you will perhaps still be experiencing some of the challenges that means it doesn't always work first time. And often it's about getting the real balance of the right person and the right way that they are deployed across a group of practices for a population that means that these roles can be successful. And I think when we talk to the future around sort of the shift of resources, the left shift, so shifting resource from secondary care into that out of hospital primary care neighbourhood setting, I think we're not going to see it necessarily in hard cash. We're not going to see a funding flow that comes, but we'll see increasingly that these roles, that this resource comes in the form of roles, in the form of staff members that might be deployed in different ways. And just building on from the mental health practitioner example, I just wanted to give an example. It's a really emerging project that's happening in with a success in North West London called Connecting Care for Children. But this project is about children in the community, and the resource that the PCN and the emerging neighbourhood have been able to secure has been the trust providing care coordinators into the community. Now, the challenge that there comes, it's great that we've got access to these staff. We can work with them in a different way, in a different setting, but that comes with that real challenge around some of the HR processes, some of the data sharing that I talked about before, but also real cultural shifts. So staff that have been used to working in a hospital setting, actually coming and being part of a primary care setting. So we're at the early stages of this, and it'll be great to kind of share some of that experience as it develops. But in reality, I think it's about people being aware that when you're looking at your neighbourhoods and you're looking at that shift of resource, it's not necessarily only going to come from the business case that proves the funding shift, but it might come from that there is resource, there is staff over here that could be deployed differently, and there's an opportunity to work with them in a different way. It absolutely takes time to get the governance right so that the patient benefit can be realised. So I think that's just something I think will be key, and as we learn from webinars like this, is that actually we can save a lot of time by areas share their examples, how they handle some of the technicalities of some of this. So I think that this will be another one to watch. So Wanstead and Woodford is in Redbridge. They're part of this, as are Havering. Havering have got a slightly different model that they're looking at. And as I said, this model builds on what would work really well in Northwest London. So we're really hoping that this is going to have an impact on how young people, children and young people, are managed in primary care, but also how they're being supported to have to need the secondary care services as frequently as they do. And I'm going to just pass back to Rachel briefly for the third case study that we were looking at. So I'll pass over to you.
Thanks, Alice. And I don't know whether I was the only one, but I think you went off in places. But yeah, but the details there, and obviously if you want to ask us about any more detail on the case study, please give us a shout. I think the great thing, just reflecting a little bit on that, because there were a couple of gaps, is the work being done as part of the ARS work for having a mental health practitioner created a very trusting relationship around the integration with the mental health services to be able to establish something, particularly for children and young people. And we know that that's a key priority in the framework. And we've done quite a bit of work around early intervention for children and young people services to help reduce to get early intervention to those children and young people that need it, rather than sitting on CAMHS waiting lists and which is not good for anyone and is also a high cost and all those sorts of things. So I think I can see there's social prescribing and link workers for children and young people are a fabulous example of how that can work, and how that could be how that works as well, pulling in our voluntary and community sector colleagues, because I noticed there's a few questions and we'll pick those up at the end around some of the data and how that links. But just moving on to the case study, as that's what I was asked to do, is this we've pulled in an example here of something that happened a few months ago, sort of before the framework landed, but it's a really good example of how services across a place-based setting look to work together to deliver urgent care. It was led as a commission service, and it includes, here we have trusts, the two trusts, the federations, local GPs, and the regional ambulance service. And I think, we've not touched on them as a partner at the moment. I think it's really important that we, as we start mapping all of our partnerships, let's not forget our ambulance trust as well. And some of the work that has to take place is to have an aligned vision. Each organisation has its vision, and actually having a look how that aligns to each other can sometimes compromise the ability to work together. So it's having a look at what those common themes are and ensure and acknowledging that these will need to align to individual organisations, but align very much into the project. So we were supporting both big management as well as the corporate governance and structure and engagement with stakeholders and mobilisation and transition. So it was really important to look at this sort of, when we say start small, this might not be where you exactly start in something of this size, but there were legal aspects to look at, the working together, the CQC arrangements around clinical governance, to look at something that was as collaborative as this. And obviously, we've talked about using population health management, we talked about engaging with the community and voluntary sector and all our partners, because we will be expected to produce business cases, we will be expected to produce bids, and our commissioners will be looking for something different to perhaps what they're used to having, and we'll touch on those in the contracts. And then supporting the mobilisation and transition, each organisation has a standard operating procedures. So how will that be managed as we start to share staff? And it was looking at what workforce has each organisation got that we can reduce duplication and variances. And that was really important to look at how we could make the most out of what we had. So we had no new money, but actually we had better ways of working by looking at what the workforce pathways, instead of it sitting in silos. So again, happy to talk about the case study in any more detail if anyone wants to give us a shout. And then if I'll just get this one, Alice, shall I? This is about, it's a learning culture, continuous improvement. If it doesn't work, then that's fine. Try something else, learn from what hasn't worked. This is not going to be a case where it's necessarily all going to work fast at the first time. And we've all found that when we're trying to collaborate in services, there will be barriers and challenges that we need to overcome on the way. We can do our very best to do that at the start, but sometimes it happens as we go along. And celebrate your wins and build the motivation and share your progress. Data, evidence will be really important to our commissioning arrangements in the future, showing how we are making that difference, particularly in our left shift, show how that integration is really working. So, it's really important that we learn and we continuously improve. And I know you're probably sitting there thinking, what's she talking about? It's what we always do anyway. And I think it's much more capturing the evidence is going to be critical for the neighbourhood projects. And then back over to Alice.
I'm not sure what's
Has
happened
the
there.
presentation gone off?
Yep, I'll share that again.
Sorry, I think I pressed it by mistake. Sorry.
It's fine, let me get it back.
If anyone's looking for technical support, please don't come to me.
So I'm sorry my Wi-Fi has wobbled there. I suppose just to finish on these points really, so we can get to some Q&A. I think what's come out of the conversation really today, the focus today is that there is that bit around finding what's going to pull people together. So working those challenges that will bring you all together, using the data, thinking about how you bring that team around you, and how you then start to think about, it's all very well to have a pilot and it's all very well to have, but we've got to start to find some ways to get some sustainable funding to follow this way of working. So it was useful to see how the data can be used to build the case, to look at the resource shift. We can also see it in how some of the workforce can move across and can be used differently. But there is also thinking about just being aware of where some of the income streams are. There's a lot of talk in the single neighbourhood and the multi-neighbourhood contracts that they'd be looking at a capitated budget for a population and looking at how that can be used differently to support that population and to make the most impact. So, and these funding changes don't come without some pain, and I think there's something around just sort of being aware of that if it's about redeploying existing funding, then for a population, then some will gain and some will lose, and it takes some of that time to manage those relationships. But the cases can be made really strongly with the data and with the information, and actually building some of that skill and that ability for those sort of multi-organization type bids will be really important. We just thinking about, we know ICBs are starting to look differently. They've come together on bigger footprints. And so we know that there's some different conversations about getting some consistency across some of the services and what that might look like, whilst also trying to align with the frameworks that talk about that real neighbourhood focus. We mentioned earlier around that emphasis on quality, so being assured that those that are at the table and that are party to these shared ways of working, that you're confident about the quality and the ability of those partners to work together, so that the outcomes that you are seeking to achieve really are able to demonstrate that new and different ways of working can secure that contract. Hearing lots about sort of unbundling of contracts and getting down to the kind of the old sort of tariffs of services, so that we can properly make some of those cases. We mentioned this more in the previous one, but this is all looking ahead to what we understand will be some of the ways that that neighbourhood contracts are going to come together. So that ability to be able to link this work and why you're doing things differently into this way of thinking is going to be key. And we'll put, because we're going to share the slides, but we were thinking about if you're pulling together key functions for a for that kind of neighbourhood and partnership working, it's making sure that you've got some of this ticked off, so that you're in a good place for those contractual conversations. So I just wanted to make sure that we've got a little bit of time for some questions. So I will hand back to Claire to coordinate that.
Fab. Thank you very much, Alice. So I have turned on microphones and cameras, but I did want to just pick up. I know we've got lots of questions in the chat, but I did want to pick up the comment that Lauren had put in your experience, the best place to start is where you have energy. So where would you want to expand on that? Where was the best place to start?
Yeah, I think it's about working with the teams that want to do something differently. There's so many places that you can start in terms of working in neighbourhoods. We knew, for example, that our frailty colleagues had a bit of capacity in how their frailty hot clinics were working. We knew that they were keen to work in a different way. We knew our frailty virtual ward wasn't quite working in the way that it might do. So understanding that there was an appetite to do something differently in that space helps us then to think, okay, what do we want to do in that area? We also knew from our neighbourhoods that from a PCN perspective, there were quite a lot of local contracts or local mechanisms to do better for frailty. So we were looking at how we could align some of the incentives and have a more strategic approach to what we were doing. I think then if you've got people pulling in the same direction, then that's really helpful. So we've tried to influence across the system to have incentives for different organizations that all face in the same direction. Then everybody, it's not on top of the day job, it is your day job. And I think we've took there's bits about in the chat around, and this is quite about health and how do we think about the VCS. And I think there's a bit about how we make sure the patient voice and the community assets are part of your solution. So you can get hung up on the data sharing but actually if you're thinking about how do you work together as a system, if this is the cohort that we think we need to do differently for, what can everyone bring to that? And actually the patient can be the person that connects those dots. So if they understand that they're part of a cohort, if they've got an anticipatory or a different type of care plan, actually they can bring people in themselves. So I think that's where we've started.
Fab, thank you very much. Kamal, I wonder if you could answer David Thomas's question. So he's wondering who is going to lead on linking the community and health services. Is it envisaged that it will be down to each neighbourhood or GP to do, or is there an overarching body in a borough that would do this? How would you go about doing that?
Probably a few answers to this question. So at the moment, health and wellbeing boards are developing neighbourhood plans, and they will probably be the centralised place where neighbourhood plans will feed into. But local ICBs are also developing their plans, not just for neighbourhood, but for ICBs generally. So those are good areas to start. And I've just seen that Michelle's put about the BCSE Health Alliances. So they have representatives at locality, at ICB level, at local level, at regional level. So definitely worth linking in, and the umbrella organisations for BCSE as well.
Okay. Thank you very much. Now we have got some questions in the chat, which we will follow up with, but I'm conscious your mics and cameras are on. Is there anyone that wants to come on and ask any questions of Lauren or Kamal? Yeah, Tracy?
I will, as I've asked loads of questions in the Q&A. I just wondered if in some areas there's the Pride in Place initiative where certain areas are getting £20 million, which isn't a lot, over 10 years, to do certain things and make improvements in their communities. I've been involved in some of the consultation work around that. And a lot of it is around health and well-being and kind of feeling good about yourself and about your surroundings. So I just wondered whether this neighbourhood approach will align with that.
So Tracy, there's so much going on at the moment. I'm really struggling. So as Claire said, I'm a regional person, so I do the whole of the Southeast. And when I've started to have a look at it, somebody's doing some work on frailty nationally and locally. Somebody's doing some work on the National Neighbourhood Programme. I spoke to Active Partnerships last week, and they've got funding from Sport England. So lots of the different organisations are doing their own thing. From my regional perspective, what I'm doing is working with our public health colleagues to try and map some of that prevention work that's happening and that community working, so that we're starting with that asset-based approach. So I think it's going to be different in different areas because we're all evolving at different speeds.
Thank you. Lauren, did you want to come in on that?
Yeah, I mean, I think although the national language of neighbourhoods is different, actually working in a neighbourhood is not new, is it? That it's actually, you know, it's the way that we're working. So I think the way the local systems need to think about this is to think about every opportunity that they have to bring in the way that the people working in their system for their population and maximize every opportunity to bring those things together. So I think if you've got multiple incentives, if you've got multiple streams of funding coming in, the more your system can think about them as a whole and be strategic in the way that you do it, that the better it will be, whether it's badged under neighbourhood health or it's badged under a different initiative. I think it's in our gift. You know, I think at the moment the neighbourhood stuff is quite permissive, and so, you know, it's in your gift to make it what you can.
Okay, thank you very much. Chandan, I hope I've said that right. Hi, sorry, you're on mute.
Apologies. I'm based at Hereford, Worcestershire, ICB, and we're looking at demand and capacity modelling, but also in the context of how the new neighbourhood teams is going to be a new one, which is one of the 43 ones that the government are installing in one of our counties. And I just wondered, like, a lot of it's about the left shift, but who's going to be there to man the left shift and the workforce? And so I just wondered if there are things being considered about demand and capacity modelling. So we're doing that in the ICB. We've just started, but I just wondered what are the type of what's the thinking about that side of things, how to model that, which is like a combination of activity, performance evaluation, and also workforce finance.
I'm happy to make a start on that. I mean, I think it is everything about data, isn't it? Is to understand where people are being seen currently and what the cost of that is and what the impact of it is it having the right outcomes, and then articulating, okay, if we moved it into a different space, how would we know whether the outcomes are better, whether the cost is different? And I think if we start working on areas where we already know that something isn't quite right, so if you've got a workforce challenge in a particular specialty in the hospital, or you've got a pathway with a really long waiting list, or you've got patients repeatedly turning up with a particular long-term condition in ED, if you start in those places where we can then think about what is there a different solution. And you're right, the workforce, it doesn't just magically appear on that, but I think we can then start to articulate what is the workforce that we need in order to do that, and can we shape that differently? I mean, I think I saw some data that suggested, you know, that follow-up of outpatient spend is, you know, more than the entire primary care budget. And there is opportunity to move things in the system, move resource, move people, but we've just got to be very strategic, I think, in deciding where best to start with that.
Yeah, no, that's really helpful. I just thought, like, we're doing that type of thinking at the ICB anyway, but just wondered how far that kind of come forward in the new neighbourhood integrated teams way of thinking, how to prioritise as well, which are the big sort of items to go for, which will have the most return of investment, and so on.
Yeah, Kamal?
I just wanted to add to what Lauren said, that I think it's a way of working as well. It's not necessarily a team. It can be, but it doesn't have to be. And I think with everything, we're always trying to set up a new service, a new way of doing it. It might be different and it might be a new way, but a lot of it, you know, it's about relationships. It's about working together. It's about understanding we've got one common pot. How are we going to split that pot of money to try and get the best value for money and the best experience for patients and staff, really?
Thank you very much. Does that help, Chandran?
Yeah, I just think, well, we've all got to keep that in mind, don't we? We've got to model the different ways of working and put some pound signs on it and evidence that this worked for us in these type of environment, and, you know, build up those case studies. So we just got to keep that in mind as we go through this journey. Thank you.
Yeah, I think that's absolutely right, because I think if you can look at the whole, you can look at the demand across the system, then you are articulating that as a different way to shape that.
Yeah.
Thank you.
Thank you very much. Are there any other questions? Anybody would like to come on camera, ask any questions? There are some questions in the chat, but I think we'll have to take them offline and get back to you with some answers. But if there's no other questions, we'll quickly skip over the next few slides, which is, what are you going to do next? So again, what are you going to do after today's session? So is it about that workforce skills mapping and the leadership structure? Is that what you're going to look at? Are you going to continue to build those relationships with the different voluntary community sectors? Are you going to start trying to determine your first cohort using those population health management data tools that we've seen today? Or are you going to start exploring funding, seeing where you can find more funding? There is, as I mentioned at the beginning, the readiness assessment that is available to do in the Digital and Transformation Hub. The follow-up email from today's session will probably be sent out next week, because we will be including our new Integrated Neighbourhood Team Readiness Toolkit. So that's kind of a step-by-step guide for you. So we will send that out next week. And then just a reminder that this is the second of a 3-part webinar series. I am just popping the link, the registration link in for our 3rd session, which will be happening on the 2nd of December, if you'd like to join that. And then lastly, we'd love to get some feedback about the session today. It'd be really grateful if you could fill out our feedback form. It really helps us to make these sessions better for you. If there's anything that we've missed, anything that you think you've got a burning issue that you think you haven't covered and I need to know X, Y, Z, please pop that in the feedback form for today's session and we'll get back to you. There is an opportunity, if you fill it out, that you'll go into a draw to win a £25 Amazon voucher. So for 5 minutes of your time, it is well worth it, just in case you win that voucher. But apart from that, I just want to say thank you very much for Dr. Lauren Parry. Thank you to Kamal Bahia and Rachel and Alice. And thank you very much to you for joining today.